This is Uma. It's a Thursday night and you're sitting office hours in the townhouses when Uma comes to talk to you. The moment she sits down, Uma begins to cry. She tells you that she was just dumped by her girlfriend and she doesn't know what to do. As an RA, one of your most important roles is providing support to your residents. While sometimes this involves pointing them toward career services or the Learning Commons, sometimes this involves providing emotional support when a resident is going through something difficult. It can also mean identifying when someone is experiencing a mental health crisis or emergency. Through this presentation, you will learn to distinguish when a resident is in distress versus in crisis and the different kinds of support we can offer. You'll learn about possible concerns that may come up and how they can be addressed. You'll also learn how to respond if a mental health concern becomes an emergency. Let's pause. This presentation will be covering mental health crises, which includes self-harm and suicidal thoughts and behaviors. This will include several scenarios with named characters who are experiencing these crises. It's important for us to talk frankly about these topics, to allow us to address them appropriately and to break down stigma. Named characters and scenarios are used in this presentation to begin to familiarize you with what it looks like to respond to a crisis in the moment. We don't want your first time looking at a scenario like this to be with a resident in real life. This allows you to pause and process what's going on when there isn't an actual crisis happening. This video will also include some animations, with still images appearing to create a scene involving the scenario. This video does not contain any images of injuries, weapons, or graphic depictions of specific mental health crises, other than some images of cartoon individuals who are upset, and one image of a cartoon person having a panic attack. Every attempt has been made to make this presentation trauma-informed. If you need to take a break, please do so. If you need additional support, please reach out to your RD or other trusted individual. First things first. It's important for us to be able to distinguish when a resident is in distress versus when a resident is in crisis. This determines what kind of support we will be able to offer the resident. If someone is in distress, it is usually a result of something that has occurred in their life, such as a failed test or a recent breakup. It is completely normal for someone to experience distressing emotions after something negative has occurred in their life, and it is also normal for them to want support in that time. A resident may reach out to you to help provide that support. But when does distress become a crisis? If someone is upset after doing poorly on a class assignment, that is considered distress. But if someone is so upset after doing poorly on a class assignment that they experience a panic attack or remain distressed for a long period of time, we would consider that a mental health crisis. So, what about Uma? It's clear that Uma is upset. Use your active listening skills and talk with Uma. Remember that you have the skills to support someone who is upset. You wouldn't have been selected as an RA if you didn't. As you're talking with Uma, she begins to calm down and eventually thanks you for hearing her out. She tells you that she's got a big test coming up soon and a game in a few days, so she needs to get back home and study. You thank her for coming to you and let her know to give herself some grace and take care of herself. You also provide her with the number for the counseling center. You tell her that she can call that number at any time to talk with someone. If she calls Monday through Friday from 9 a.m. to 5 p.m., she'll reach someone in the counseling center itself. But if she calls at any other point in time, she'll reach our after-hours counseling line, where she can speak to someone to get support. It's important to remember that while we can support our residents when they're in distress, we aren't a substitute for mental health support. The counseling center can help provide longer-term solutions, and the after-hours line can help connect the resident to longer-term support if needed. In this situation, we were able to see that Uma was in distress, but wasn't in crisis. Uma was upset, but wasn't so upset that she had difficulty calming down as you supported her. It was also clear that this wasn't something long-term she was managing, but something that had recently happened. But what if someone is in crisis rather than distress? Let's talk about some common ways that mental health crises can manifest and some tools for you to be able to manage them. Please know that it is not your role to diagnose residents as you are not a mental health professional. However, there are some experiences that are important for you to be familiar with. There are also some ways that you can provide support without needing to be a mental health professional. We'll have an example scenario in a minute, but let's talk through some crises you may encounter. First, let's talk about panic attacks. When somebody is experiencing extreme anxiety that causes them to have difficulty breathing or focusing on the world around them, that may be a panic attack. It is important to remain calm yourself as you provide support. It's common for us to mirror the emotions of those around us. If our friend is sad, we will appear as if we are sad as well. If our friend is stressed, we may appear stressed as well. This is normal and is a part of having empathy for the people around us. However, once somebody is experiencing a panic attack or other mental health crisis, it is important for us to remain calm and not mirror that level of stress. Take a deep breath. You may find that the resident ends up mirroring the calm you are showing. Panic attacks may be caused by a number of different situations. They may be a result of an anxiety disorder. They may be a result of post-traumatic stress. They may be caused by something else entirely. Again, it's not your role to diagnose the resident. If someone has experienced a panic attack before, they may be familiar with what is helpful to them in that moment. However, it is helpful for you to have a few grounding techniques that you can bring up to help a resident feel more calm in the moment. What are some examples? A common one you may have heard of is box breathing. Breathe in for 4 counts. Hold your breath for 4 counts. Breathe out for 4 counts. Hold your breath for 4 counts and repeat. Box breathing can help someone regulate how much they are breathing, telling their body to calm down. This can reduce the intensity of a panic attack. However, for some people, box breathing can be too much to focus on, depending on the severity of their situation. Another good tip is to ask the resident to hiss and breathe out for as long as possible before breathing back in. It may seem silly, but this can trick the nervous system into relaxing more and can be easier for someone to focus on when they are in distress. Another potential grounding technique is asking the resident to focus on the room that they are in. Name 5 things that you can see. Picture, books, notebook, paper, lamp. Name 4 things that you can touch. Curtain, plant, chair, keyboard. Name 3 things that you can hear. People outside, ticking clock, video on the computer. Name 2 things that you can smell. Plant, flower. And name 1 thing that you can taste. Drink. An alternative to this is asking the resident to name 1 item they can see for every color in the rainbow. Red, orange, yellow, green, blue, purple. This can help bring the resident back into the space they are in and help them feel more grounded. Different techniques will work for different people, and a resident may have another technique that they find useful. But having a few grounding techniques in your toolbox can be helpful. You can also use these techniques yourself if you feel the need to. This is an example of an acute mental health crisis, meaning that it is happening in the moment and can be addressed in the moment. While someone might need long-term support to prevent and address future panic attacks or other similar incidents, you are able to provide support in that moment and see the results yourself. However, there are other mental health crises that you may encounter in your role that are not as easily addressed in the moment. It is possible that you will encounter a resident who experiences a long-term mental health crisis that they are managing. Examples include long-term anxiety disorders, severe depression, eating disorders, post-traumatic stress disorder, amongst others. The reality is that while we can provide a level of support as residential life, ultimately we are not a mental health service. Residents can connect with the counseling center or off-campus mental health professionals to manage those conditions. If you become aware that someone is struggling, it is important for you to make a note of this and inform professional staff. You will do this by submitting a student of concern report. You'll receive specific training on this in another video. Let's move to the next scenario. This is Whitley and this is Xiaomin. They are roommates. You're having a catch-up conversation with Whitley when she tells you that she's worried about Xiaomin. Apparently, when Xiaomin was changing the other day, Whitley noticed scars and cuts on Xiaomin's thigh that looked to be self-inflicted. Whitley is worried that Xiaomin might be self-harming. Your first step is to ground yourself. Take a deep breath. This can be a difficult thing to hear and talk about. You thank Whitley for coming to you. You ask if she's spoken to Xiaomin about it. She tells you that she didn't want to bring it up because she didn't want it to be awkward. You ask Whitley if she's noticed anything else that might be concerning or if Xiaomin has mentioned anything that might be going on for her. Whitley says no. What now? First, we need to talk about the difference between suicidal thoughts and behaviors and non-suicidal self-injurious behavior. It's a common misconception that if someone self-harms, they must also be suicidal. This is often not the case. There are a few key differences for you to be aware of. First, intent. Self-harm is a coping mechanism that someone may use to feel better. Suicide means that someone made the decision to end their life due to overwhelming emotional pain. Second, frequency. Self-harm may be used regularly or off and on to manage stress and other emotions. Suicidal behaviors are much rarer. Finally, method. Self-harm often involves methods that cause damage to the surface of the body. Self-harm is dangerous, but isn't meant to be lethal. Suicidal behaviors are meant to be lethal. If you become aware that a resident may be self-harming, it is essential that you contact professional staff. However, we consider non-suicidal self-injurious behavior to be a crisis, but not an emergency. This means that while we will follow up quickly, we aren't going to necessarily follow up with the resident immediately. You call the RD on duty to talk through the situation. Remember that when you are calling up for assistance to let the RD know who you are, where you are, what has happened, and what you need. For example, this is R.A. Allery in Martin Hall. I'm with a resident, Whitley, and she's just told me that she believes her roommate, Xiaomin, may be self-harming. I'm looking for advice on how to proceed. The RD will likely ask follow-up questions to assess the situation. Their main goal will be to determine if there is anything to indicate that we need to address the situation that night, rather than the next day. The RD speaks to you and Whitley over the phone and determines that there is nothing that indicates the need to follow up immediately. They instruct you to submit a student of concern report and let you know that they will follow up with Xiaomin the next day. The RD chooses to wait so that Xiaomin doesn't feel ambushed in the moment, where there isn't any immediate action that is needed. You make sure to let Whitley know about the counseling center and their after-hours line. You let Whitley know that she can call the line to receive support, as well as Xiaomin. The RD follows up with Xiaomin the next day. You follow up with Whitley in the next few days to see how she's doing. Let's pause. For privacy reasons, the RD likely won't give you any details about their follow-up with a resident in a situation like this. It's important that we keep as much information private as possible. But there is a difference between private and confidential. You are not a confidential resource. You may have heard that said around Title IX and bias concerns, but it is also true for mental health. You will report up, not out. This means that you can and should share information with your RD or other professional staff as needed, but you should not share information with fellow RAs, residents, or anyone else. The only exception to this is if you are speaking to a licensed mental health professional who is providing you support as their client. You can talk to your therapist about private matters, but not your fellow RAs. It is also possible that a resident may be upset with you for calling for help. Xiaomin may be upset with you or with Whitley for reaching out for help. Remember that it is still your responsibility to call for assistance, and it's important to remind Whitley that she did the right thing letting you know. It may be important for you to do some repair work with Xiaomin later on. Talk with your RD for assistance. Final scenario. It's 8 p.m. on a Friday night. You're in your room catching up on some homework when you get a knock on the door. When you open it, you see one of your residents, Virgil. Virgil looks nervous and tense. He asks if he can talk to you. From his demeanor, you get the sense that this may be a serious conversation. First things first, safety. Your safety is the number one concern. While we often think about physical safety first, emotional safety is just as important. Take a moment to ground yourself. Remember that you have the training to manage situations like this and support is just a phone call away. Physical safety is also important to consider. In this situation, you aren't noticing anything that could pose a physical safety concern. Let's pause. There may be times when a mental health emergency may involve physical safety concerns. It is extremely rare for an RA to encounter this kind of situation, but we want you to be prepared. Take note of any injuries or signs of potential overdose. If you are in the resident's room, take note of any potential weapons or other concerning items. If there is a weapon present, let the resident know that you need to step out and contact security, then the RD on duty immediately. Your safety is the number one concern. If you encounter a situation where someone is injured or experiencing an overdose, use your training in managing medical emergencies. You decide to head to his room with him to chat. It would absolutely be appropriate for you to invite Virgil to speak to you in your room, but it is also appropriate to take the conversation to a neutral space. This is based on your personal boundaries and needs. We provide you with a single room to assist in this, but you may have housemates or suite mates that can complicate a conversation like this, or you may wish to have a safe space to return to if you suspect the conversation may be difficult. You could also meet with the resident in the RA office. Offer the resident options of where to chat so they are the most comfortable. Virgil tells you that his roommate and suite mates are not around, so he wants to talk in his room. You go with Virgil to his room. Let's pause. In this scenario, you are not the RA on duty, but a resident of yours is clearly in distress and may be in crisis. You're not sure what the situation is, but you do know that Virgil felt comfortable enough to come to you. In situations like this, you are expected to respond to the best of your ability. If Virgil is in crisis, we don't want him to feel like he isn't being heard or supported. The RA role is sometimes unpredictable. You sit down with Virgil and ask what's going on. He lets you know that he just found out he failed a test and will likely not be able to continue in the nursing program. He tells you that it all feels hopeless and he isn't sure if he can do this anymore. At this point, you are noticing several red flags that Virgil may be experiencing suicidal thoughts. You remember your training through MindWise and respond. Remember that the most important thing at this point is to ask if Virgil is experiencing suicidal thoughts. Some examples of ways to ask the question include, I'm hearing you say you're not sure if you can do this anymore. Are you having thoughts of killing yourself? I'm so sorry that happened. I need to ask, are you having suicidal thoughts? I'm worried about you. Are you thinking about killing yourself? It may feel awkward or jarring, but it is absolutely essential that we ask this question. A good tip is to practice asking in the mirror or with a friend prior to encountering a mental health emergency. The more comfortable you are asking the question, the more comfortable they will feel answering. You ask Virgil if he is having thoughts of killing himself, and he says yes. Now what? There are two possible next steps. Which one you choose depends on what time it is. The main priority is to get the student to speak to a mental health professional who can determine the next steps. This could either be a person in the counseling center, if it's during regular business hours, or an after-hours counselor. If it's during regular business hours, Monday through Friday, 9 a.m. to 5 p.m., you should call the RD on duty first. Let the resident know that you're doing this. Thank you for telling me. I'm worried about you and I want to make sure that you are safe. I need to call my supervisor, the RD on duty, to get some help. They're going to make their way over here. The majority of emergencies happen after hours. Remember that it's 8 p.m. on a Friday night. So now what? Remember that PACE provides after-hours support. We work with an organization called Protocol to provide this. In general, you should refer to this support as our after-hours line for the counseling center to avoid confusion. But when talking to other staff, you can call it Protocol. You tell Virgil, thank you for telling me. I'm worried about you, and I want to make sure that you're safe and get the support you need. I need to have you speak to a counselor. While you're talking with them, I need to call my supervisor, the RD on duty. You ask Virgil to pull out his phone and call the number for the counseling center. After hours, this number redirects to Protocol. Once you confirm that he's speaking with a live person, you step out to call the RD on duty. Let's pause. If you know that a resident is experiencing suicidal thoughts, you need to contact the RD on duty. This is not a choice. The RD needs to be contacted. Remember that safety is our number one concern. If someone is experiencing suicidal thoughts, we are concerned that the decisions they make may not be the safest for themselves. That's why it is essential for us to respond. If Virgil had said he didn't want to call the counselor, you still need to call the RD on duty. They will respond in person to assist. Do not leave the room until the RD on duty arrives. When you are calling for assistance, remember to tell them who you are, where you are, what has happened, and what you need from them. For example, this is RA Joanna in Alumni Hall. I'm in Alumni 236 with Virgil. He's let me know that he's having suicidal thoughts. He's currently talking to protocol. I need to let you know. The RD on duty will likely ask follow-up questions and can also provide support to you over the phone. After 10 minutes, Virgil opens the door and asks you to come back inside. The counselor from protocol lets you know that Virgil needs to go to the hospital. Let's pause. The main function of the counselor is to determine what level of risk there is. Just because someone is having suicidal thoughts doesn't mean that they are at imminent risk of suicide and need to be transported. In this scenario, we elected to have the character Virgil need to be transported to help you know what to do if you are involved in a mental health transport. But often, students experiencing suicidal thoughts are not transported. The counselor has received special training to determine if Virgil needs to be transported or not. Please know that it is not your role to determine the level of suicide risk. It is also not the role of professional staff. Several members of our professional staff are trained mental health professionals, but even though they may be trained to perform the assessments the counselor does, that is not their role in responding to mental health emergencies. Once the counselor has determined that Virgil needs to be transported, they will contact security and the RD on duty. You sit with Virgil while you wait for professional staff to arrive. It may feel like it takes forever in a situation like this, but professionals will arrive within 20 minutes. What do you do in the meantime? Ask the resident what they need in the moment. They may not know what they need, so you can have some suggestions ready. You can use some grounding techniques. You can talk about unrelated things to distract them, like movies or video games. They can also choose to just scroll on social media or listen to music. They don't need to talk anymore if they don't want to. At this point, the situation is similar to a medical transport. The RD on duty and emergency personnel are managing the situation. Remember that one of your roles is to assist with crowd control. This is especially important in a mental health emergency. Also make sure to grab the hospital transport card for the resident. Virgil is transported to the hospital. Let's pause. It's entirely possible that you may see Virgil back on campus the next day. It's important to know that just because someone is transported for mental health reasons, it doesn't mean that they will be off campus for an extended period of time. They might be, but they might not. Know that if someone has been released from the hospital, it is because mental health professionals have determined that it is safe for that to happen. You won't know the details. However, it is absolutely appropriate for you to check in with Virgil and see how he's doing. While suicidal thoughts are the most common mental health emergencies that are seen on college campuses, they are not the only potential mental health emergency. It is extremely rare for you to encounter one of these other potential emergencies, but it is important for you to be aware of them as a possibility. Other emergencies can include acute psychosis, where a resident is experiencing a break from reality. This is sometimes drug-induced. Violent or aggressive behaviors, where someone is a threat to others and cannot be de-escalated. In any of these situations, recognize that there is a safety concern and remove yourself from the situation. Then, call security and the RD on duty. In this presentation, you have learned how to support residents experiencing distress, mental health crisis, and a mental health emergency. Remember that you have the skills needed to address these situations, and help is only a phone call away.